Guys, Woodruff here. This next section is going to be about increased ICP. And if you're in med-surg, you might be like, I don't see anything about this in the objectives. It's not necessarily, you're not going to be tested deep over this, but it involves some of the things we're talking about, especially when we talk about stroke. So I'm just kind of introducing this topic to you because you will learn about it in complex. But I would definitely watch this video because there's stuff in this that will be super helpful for you and will potentially be tested over. Even though you're not going to be tested over increased ICP specifically, some of the patients that we talk about in neuro are going to need interventions to manage their intracranial pressure. So you need to know it. So what is, oh yeah, let me back up. What's the big deal with increased ICP? So in this picture, this is like a normal brain. You see all this white space around on the outside. That's your skull. There's space there you see. And this is someone with increased ICP. You see how the white, there's a lot less space because the brain is expanding out. And you can see it's also there's less space here in the middle, like here that you can see the ventricles, this black space in the middle. You're supposed to have that. You do not see that here. And so stop, Jesus. Oh no, come on, Jesus. All right. The big picture here is that with increased ICP, the big deal is think of it almost like when we talked about compartment syndrome, where you have this expansion, in a limited space for it to expand. The same thing can happen in your brain. So injuries, other things can happen in your brain, such as a stroke, that can lead to like inflammation. Inflammation is swelling, and your brain is limited by your beautiful skull. I did have a student recently ask if the skull would just start expanding, but your skull fuses after a certain point when you are younger, and so there's no room for your skull to get bigger. So if your brain is expanding out, but it keeps expanding, it has nowhere to go. What it does is it goes down, and if it goes down, it pushes on the bottom part of your brain, which is your brain stem, which is responsible for your ability to live, like breathe, have a blood pressure, heart rate, all that stuff. And so it can lead to what we call herniation. So this is a very big deal because the end result is if the brain has nowhere to expand, it goes down, and then that can lead to what we call brain death. So, to work well or to have good, like manageable pressure, just like we need blood pressure, we don't want too much, and we need enough. The same that you need intracranial pressure and you want not too much, but enough as well. So, what things support, and these are the things you want to think about how that you as the nurse can start to help a patient who maybe is at risk for brain swelling, has brain swelling, or has that increased intracranial pressure. Is we want to think about making sure that they're not too overstimulated. Pretty much if the brain is working super hard, it uses all of its energy. And so in order to work well, it needs to, not be overstimulated. I use this as the excuse of why I'm so antisocial, but I really can't use that. But stimulation can come in a lot of different ways. It can come from noises. It can come from that's why there was one time I had a patient who had increased intracranial pressure, and I guess that the family misunderstood what the doctor was saying because the doctor said, yeah, we're trying to see if they're able to wake up. So the family took that as, oh, we're trying to wake them up. So the family went in with like a boom box, no joke, and was blaring some loud music. Trying to wake this patient up. But here's the thing is that the brain works well, but it does not need too much stimulation. And again, it causes it to work hard. It uses all of its energy. Another thing that can cause stimulation or use energy in the brain is things like fevers. So the brain definitely needs to not be in overdrive or overworking itself. It needs enough oxygen. So the brain is very oxygen dependent. So when these patients with increased ICP present, we usually hyperoxygenate them or give them extra oxygen because it's that whole supply and demand. So think of it like angina, but in the brain. I'm always going to bring it back to cardiac. So it's like angina, but in the brain. It needs to have enough oxygen to be doing okay. It also needs not too much carbon dioxide because carbon dioxide is a potent vasodilator. later. And what I mean by that is if you have too much carbon dioxide, it builds up and it leads your blood vessels to relax, which might seem like a good thing because you're probably like, oh yeah, you don't want to be constricted. But here's the thing is that vasodilation is good to an extent, but if I'm vasodilated, the vessels before my brain are not going to have the squeeze they need to pump that beautiful flow into my brain. So it's going to decrease flow to my brain. And then the vessels in my brain are also going to be relaxed. So there's not going to be good flow. There's too much of a good thing sometimes. And so you have to think about too, someone that has extra pressure in their brain or someone that's had like a stroke, they're also going to have usually maybe a change in level of consciousness or not be as awake. And so we have to think about like, why is this such a big deal? Well, a patient, like for example, a stroke patient, they're not as awake as maybe you and I are. I mean, you may be falling asleep during this lecture, but like, let's be honest, you have some sort of level of consciousness. But at the end of the day, when it comes to it, is that you have to remember what puts people at risk for having increased CO2 or carbon dioxide. And that's like thinking like the respiratory acidosis. And that also included sedated patients or people with like opioid overdoses or people that were like mentally not as awake. Because it all has to do with the amount of times you're breathing per minute. So the point I'm getting at, if you're getting lost and saying, what is this lady saying? This is that I'm telling you that patients that have neurological problems often are going to have a decreased level of consciousness. They're not going to be breathing as fast. So they're going to be retaining CO2. So they're going to be at risk for this. So I need to watch their oxygen getting in, but I also need to make sure they're breathing enough times per minute to get that waste out. Otherwise, their blood vessels are going to dilate. It's going to decrease the flow to their brain, make things even worse. So even if you look at a patient, you're like, oh, my neuro patient, they're really relaxed. Yeah, too much relaxation can be not a good thing. We also need good flow. So you have to think about like, the blood vessels to my brain as like hoses. If there's a kink in one of them, or if it's clamped off, they're not going to be able to, what do you call it? They're not going to be able to, be able to get the good flow. I'm sorry. I had a brain fart for a second there. So what I want to think about is like with this patient, when I'm looking at their head position, is we don't want their neck turned too far to the side. We want them to, kind of have a neutral, not kind of, we want them to have a neutral neck so that these beautiful blood vessels that are putting flow to my brain can allow for better flow. And you'd be surprised, like sometimes like when I go in, if I have a patient that has increased ICP, the first thing I do is look at the position of their head and neck. Because if their head is clamped over to the side, there's times that I've straightened and put like towels and stuff to keep their head straight. And their ICP will go down by like 10 points just because there's improved flow. I'm not saying it always happens, but it can help. And then also the brain needs, not to be swollen or injured, of course, but if it is, we need to decrease some of that edema. So we usually like, an elevated head of bed because just like, let's say we talked about with fracture, you have a broken arm, you want to elevate it. It decreases the edema. Same thing. If my brain is swollen, I want to elevate it. So I do that. Now we don't like their head of bed too high because we don't like, I'll talk about the flexion thing here soon. But it increases your intracranial pressure if you're sitting too high. So we usually like them right at 30 degrees, no more than 45 degrees. So I'm expecting someone who's having like intracranial pressure issues to have a decreased level of consciousness. Usually they're going to have something altered there because extra pressure, the brain shuts off and says, hey, I can't do this right now. They could be confused. Other common neurological symptoms are going to be things like they might have headaches, they might be vomiting. We're going to do a Glasgow Coma Scale, which I'll go over in the next video. And that tells us how awake they are, ability to follow commands, like their motor abilities, things like, and their ability to speak and stuff like that. Pupils are also another priority assessment because a lot of times they can tell me something. Now, that's not an early sign. That's a late sign that there's a problem. If I go in and my patient's pupils are fixed, dilated, there's a serious problem, and it's probably pretty far, but pretty far down there. That like the early signs and symptoms we look for neurological problems are a change in level of consciousness. The late signs are going to be things like pupils and changes in vital signs and stuff like that. We may get a CT or MRI. That's usually the first thing, is get a stat CT, see what's going on inside. Someone with increased ICP is getting better if they're, we look for signs of neurological improvement. So they're more awake, they're more oriented, they can follow commands. And I'll talk about this more in my GCS video, but commands to me is not like squeeze my hand because that's a reflex thing, but I want to say something that they have to process and think and then complete that action. So it'd be like, give me a thumbs up. We caught or I might ask them to raise their eyebrows or stick out their tongue, something that I'm sure that it couldn't just be random chance or occurrence for them to do it. Better pupillary response, maybe improving their reflexes. There's a few different reflexes like the cough, the gag. There's also the corneal reflex. I'm not going to get into those, but if those were maintained or improved, and then stable vital signs too, because remember, like the worse my ICP gets, the more pressure in my brain, the more likely I'm going to get that pressure on my brainstem. And you'll learn about what's called Cushing's triad in complex, but effectively it's like kind of like it's a I call it a triangle sign, but it's 3 signs of increased intracranial pressure, and we'll talk about it here in a second. But that's definitely, we want to keep things stable because if they're getting to that Cushing's triad, it's a sign that they're having pressure on their brainstem, so things are pretty severe. Of course, the opposites would be that they're getting worse, that less awake, less oriented, unable to follow commands if they're doing like posturing behaviors, which we'll talk about on the GCS video, having fixed pupils, loss of reflexes, that gag, cough, and corneal. A gag is the ability, like, usually like we'll try to suction them or stick something in the back of their throat, see their response. Their ability to cough independently, is great. And then corneals is where you touch on the eye. Like normally if you touch someone's eye, their eye is going to try to close to protect it because it's like, hey, something's coming in. But with a poor neurological response, you could touch someone's eye with a Q-tip, or usually we use like a gauze, and they're still they're going to not blink or do anything. They should be blinking. And then the last couple signs here are going to be signs of, and I need to add one on this. There's going to be signs. So the Cushing's triad thing I told you about, this is the very late sign. The parts of that is the widened pulse pressure, which means the top blood pressure number, the systolic, is going to be really high, and the bottom number is going to be normal, or it's like going to be very far apart. So this would be like a blood pressure of like 200/70. So there's going to, just think there's going to be a lot of space between the top number and the bottom number. They're also going to have a low heart rate. And then usually the third part that I forgot to add here is irregular respirations. And they usually do stuff like Cheyne-Stokes, and Cheyne-Stokes breathing is like where they sit there. I'm sorry, that doesn't sound right, but pretty much what their breathing would look like. It's where they sit there and they don't breathe for a while, and then they'll go, and then it's just like they stop, and then there's no breathing for like a prolonged period of time, and then it's like really rapid, shallow, and sometimes it can be rapid, deep. There's a variety of different, there's like agonal breathing too, but effectively think irregular respirations. And those 3 things, the wide impulse pressure, bradycardia, and irregular respirations, that's your Cushing's triad. Projectile vomiting can also be a sign of worsening. So medically, what do we do? Now, you are not responsible for knowing deep treatments like meds, but just know you're going to learn about it in future semesters. There's special diuretics we can use to decrease pressure in their brain. We can also use what's called hypertonic saline. Effectively, what it does is it's really salty saline. Oh, that's funny to say. Really salty saline. And what it does is it pools some of the it pools fluid, because like water wants to follow wherever all the salt is. And if there's a bunch of salt in the bloodstream, all the water that's hanging out in the brain cells is like, hey, there's a whole bunch of salt over in the bloodstream. I'm going to hang out over there. So it just helps to get rid of excess fluid. So we're going to get rid of fluid. We're going to decrease things that increase our ICP. So we'll talk about those soon. We're going to manage blood pressure and other vital signs, make sure that they're staying stable. They can have a variety of temperatures. They can have like neurofevers. And these are the hardest things because with when someone has like the loss of the regulation of their brain, of their in their brain for their temperature, like there's no amount of Tylenol that's going to fix that. We kind of talked about that when we talked about heat stroke and stuff. When you get to the point your brain can't regulate your temperature, Tylenol's not going to do it. So with these patients, we have to do a lot of environmental stuff, and a lot of them are just going to keep a fever, and we can't do anything about it. But we really want to, because remember, we don't like them to have those fevers because it really works their brain hard. And then a very low stimulating environment. So let's look at each of these things. Here's a little activity. Which of these increase, decrease, or have no effect on intracranial pressure? So if we put someone's head of bed 60 degrees, is that going to increase, decrease, or have no effect? So for this, it's going to increase my intracranial pressure, which is not good. And so remember I said before, we like them at 30 to 45 degrees. So why don't I want them at 60? It seems like, I mean, hey, if they're not conscious or a decreased level of consciousness, I would want them up, support their lungs. But here's the thing is that we want to avoid any flexion. We don't want flexion of the neck because that affects blood flow. We also don't want flexion of the hips. If they're sitting up too high, especially, we do not want them at above 45. We do not want them very high. The flexion of the hips, believe it or not, actually increases your intra-abdominal pressure. And if my intra-abdominal pressure is high, it increases my intracranial pressure. So pretty much it's just like what do you call it? Other pressures in the body. When they're stimulated, they can increase my intracranial pressure. So 30 degrees is best. So that will increase. And now when I say increase, it's not good. I should do this. Increase intracranial pressure. Temperature 102. So remember for this, I said that fever increases metabolism. Like my body is working hard to try to regulate that. So that's going to make my brain work really hard. And things that make my brain work hard are going to increase my intracranial pressure. Administering potassium. So, you could definitely create a story here, but just the act of administering potassium is going to have no effect on intracranial pressure because it's potassium itself. You do need to have things balanced, but potassium itself would not have a sharp increase in intracranial pressure. Head and neck in a neutral position. So that's where we want everything straight and aligned. And like I said, I kind of use rolled towels with pillowcases and stuff around them to keep their head and neck neutral. This is something that's going to decrease. Oh, so let's see where my finger is. I'm in Harry Potter's castle. I'm lost. There we go. This by my face. That's really awkward. Ooh. Wait, called so it's gonna decrease. Maybe I'll just do maybe this hand. Oh no. Oh yeah, there you go. Decrease. And so it's going to decrease my intracranial pressure. And that's a good thing. I do not want low intracranial pressure, but I want it managed. I don't think I brought it up, but normal is like 5 to 15. So we really like it in that 5 to 10 range when we can. Blood pressure 70/40. So this is a very low blood pressure. So if I have a low blood pressure, how much flow can my brain be getting? If I have a low blood pressure, I'm not going to be getting good perfusion. So this is going to increase my intracranial pressure. So you may be sitting like, oh no, it's going to decrease. Intracranial pressure, don't think of it like blood pressure, like is it high or low? Think of it like how much swelling there is. So things that increase my intracranial pressure increase the swelling. Things that decrease the swelling. So if it helps to think of it that way. So if I have less blood pressure, I have less flow, and I have less flow, I have less oxygen. If I have less oxygen, I have more swelling. And all right, avoid turn. So this one, so far we have, this is going to increase or worsen my intracranial pressure. This is going to increase or worsen my intracranial pressure. This is going to do nothing. This is going to decrease or improve my intracranial pressure. The blood pressure is going to increase or worsen my intracranial pressure. So now we have avoid turning, coughing, or deep breathing. So these are all things that we usually love patients to do, but with patients with intracranial pressure issues, we do not like them to, I sounded like I was about to sound like a Dr. Seuss novel. We do not like it anywhere. Like I was thinking of that one about ham. No, is it ham? What is it? Green eggs and ham. That's it. Yeah. Anyway, back to the topic. Avoiding turning, coughing, and deep breathing is actually something we want to do in these patients because we really want to avoid any sort of extra pressure. So this is kind of the same thing as the flexion in the hips. If they're turning, coughing, deep breathing, it's a lot of stimulation. It increases our intra-abdominal pressure. It's no bueno. So that would increase or worsen my intracranial pressure. Preventing constipation. This is actually something that can decrease my intracranial pressure. So it's a good thing. It's going to decrease or stabilize my intracranial pressure because if someone is constipated and they're straining, working really hard to have a bowel movement, it's going to worsen their intracranial pressure. So if I'm preventing that, it's going to be a good thing. So preventing constipation decreases my intracranial pressure. Heart rate 99 beats per minute. Now, I know y'all are gonna hate it because you're like, "It's really close to tachycardia," but it's at 99, it's still normal, so I would say this is gonna have no effect on my intracranial pressure. As long as I'm staying normal, I should be good to go. We wanna keep normal, stable vital signs. A large family that visit all day. That is going to increase my intracranial pressure, or make it worse because, lots of noise and stimulation. So we actually sometimes have rules or like, how much people are allowed to visit, how many people are allowed to visit, how much stimulation. A lot of times these patients will have signs outside the rooms that say like, see the nurse before entering. And it's hard to do it sometimes, but the best thing we can do sometimes is tell people like usually family members for a good reason. And it's a very sweet thing to do, want to talk to their family member and like, just like talk to them constantly. This is not the kind of patient that needs that. You can go in and say, "Hey, I'm here. Just want to let you know I'll be sitting with you," but not a lot of talking, not a lot of interaction. Other patients, great, do it. I love it. But with these patients, they need silence. So also, most patients for me at night, because I do night shift, I'll turn on music for them and, play stuff in the background just to try to be calming for them. For this patient, I want to like very strongly avoid that because that constant noise, that constant stimulation is going to keep their brain overstimulated. So what are we gonna do as the nurse? Head of bed, like I said, 30 to 45 degrees, keep that head position neutral. I'm gonna be concerned about anything that's gonna cause them to be agitated or distressed. And it's a really hard balance for patients with increased ICP. I wanna make sure that they are not sedated too much because I wanna be able to do a regular assessment on them. And everything about sedation and pain medicine and stuff like that is not good for ICP. And I'm not going to go too deep into this, but you have to think about it. Like everything with pain medicine lowers everything. It lowers your respiratory rate, which can increase your CO2 and worsen your intracranial pressure. It decreases your blood pressure, which can then decrease the flow to your brain and mess with that. And then again, it also decreases your ability to be able to do a good neurological assessment. All right. And then so what I was saying is that there's like a fine balance. So we want them sedated enough because like sometimes it's like really a hard balance because it's like they're either really agitated or sedated. Like and we really don't like either of those options, but sometimes we end up like trying to find like a middle ground there. We're trying to prevent and control fevers and then yeah, just kind of watching their level of consciousness, their respiratory rate closely. So that is increased ICP. The next video will be about level of consciousness versus orientation, all about the Glasgow Coma Scale. I'll see you for that one.